Hello everybody, hello, how's it going? I hope you're all keeping safe. Thank you for joining me. Today I'm going to do a lecture, just basically called Playing with Colour. It's going to be around about 45 minutes, around that sort of time long. The reason I called this lecture Playing with Colour, because a lot of the materials and a lot of the restoratives we do and a lot of our dentistry, it's all surrounding with colour and how light interacts with the teeth, how light interacts with our own eyes, how we analyze it, how we recreate it. So it's one of the fundamental cornerstones of good restorative dentistry, and for me it's been one of the hardest. So I just wanted to briefly touch what we can do in our daily sort of restorative work, of how it integrates, how we can assess it, what kind of materials we can use that can make our life a bit easier, a bit more simplified. And then if we want to go complex and we want to play around with more intricate colors, more subtle colors, how we go about this. So or far away. I'm here at my clinic. It's in Oxfordshire. I do a lot of restorative and implant dentistry. I also do a lot of my teaching here, in especially anterior, posterior, direct restorative dentistry. Make a note of my email. If should you have any questions, give me a shout, and I'll be happy to answer them. I think there's a Q&A section as well, so do submit your questions. Also, you're welcome to go on my social media. There's a lot of frequently asked questions on there, so I've answered a lot of it from there. So if I get the opportunity to see you, that'd be great, or if you get the opportunity to come see me one day, that would be also fantastic. As with all my lectures, any products and sort of that I use are from my own personal experience. This lecture is supported by Tokiyama, but my relationship, it's almost synergistic in the way, because I used them for many years beforehand. And actually what this lecture and a lot of my teaching is just materials that I use every single day. And if you follow me on social media, there's a lot of everyday stuff, and so it's quite easy for me to talk about certain materials and certain companies that I use, because I've been using them for many years and I've seen the results and I've seen what their recalls are like. So it's my own observation, but it's what I do for many years in my own clinic, and it seems to work for me. So all I do is share it, and I hope it helps you. I just normally say with any sort of lecture or teaching I give, just please use it for your own learning and education. I don't mind that. But just try to be respectful, and if you have any questions or any queries, then give me an email. So for me, sometimes what you cannot see is just as important as what you can see. And what do I mean by that? So to the naked eye, when we look at, say, a tooth, for example, sometimes we're just looking at the basic things like the outline, the shape, the simple color transition, maybe even the gum. So we're looking at very basic sort of, and so we should. But there's a whole hidden, it's just the tip of the iceberg, as I like to say. And if you study teeth in a lot more detail, from all different types, from not just age but ethnicity, and also what happens to the life cycle of a tooth in terms of iatrogenics or trauma or restorative dentistry that's carried out. All these things have a massive effect on how the tooth optically behaves. So for example, if we talk about, fluorescence of a tooth, we know that a lot of the fluorescence is derived from the dentine of a tooth. But we don't see that in everyday. We don't look around with on people's teeth unless we're working in a club or UV sort of environment. We don't really see the fluorescence of a tooth. But it's important to know that there is that element, and it's important to know, why that element and why there's that, and whether our materials do have that, and to what degree. So that's just an example of what I personally believe, that we need to understand how our restoratives behave in multiple light situations, and also how the tooth evolves over time to behave a little bit differently and looks a bit differently. And we need to understand why those things happen. So one of the things that I just mentioned there is that we've got these colours in teeth, and one of the things that we generally know is that most teeth shades are within the A range of the spectrum. The A1, the A2, A3, A3, rather than the Bs and the C shades. If we're going on the basis of the Vita sort of shade guide, which is, as most people will tell you, is sort of an archaic analysis of colour, but it was one of the fundamental sort of cornerstones to many dentists these days in how they assess colour. They still use that as a reference. Gradually over time we're moving away from it. We're creating our own custom colour analysis via digital means or via custom shade guides, etc. So that's the evolution of dentistry in terms of colour. But if we understand that most teeth are in the red-yellow spectrum of light, and the warmer tones that we see are normally in an A range. We sometimes see grey and blue in teeth, and we see that a lot, especially bluey sort of opalescent characteristics. That's normally in the incisal third, especially in young teeth, and we'll sort of explain that a little bit later on. And then you've got orangey brown, so certain teeth discolor to orangey brown. There's trauma or developmental related issues, so we know that so pulpal trauma releases the iron, and then that can create internal discoloration. So all these factors are critical. And if we go even to black or metal, so if we've got old amalgams or contamination or previous posts or similar external sort of things that have happened to the tooth, do we just drill away at the natural tooth until it disappears, or can we maybe conserve tooth structure and maybe use opagas or different sorts of materials that can help conserve tooth, and also which we know that will prolong its lifespan of a tooth? And also, can we get the same great result without drilling as much tooth as we maybe previously thought we needed to? So I tend to lean towards the sort of latter the spectrum, where I would rather opaque than drill away natural more natural healthy tooth. Although it may be discolored, it still may be perfectly healthy and not need to be drilled. So I do see a little bit of iatrogenics and damage caused by a lot of dentists over drilling away at discolored tissue, even though it may be relatively healthy. And so this is where, if we have a good understanding of some of the optical characteristics such as opacity and the layering of certain materials, it will help sort of conserve and therefore sort of avoid a lot of long-term problems that can develop. So when we look at young teeth, it's quite interesting because we talked about the blue and the colours that you can get. Generally with younger teeth we have untouched enamel, so you can normally see the pericymata. It's lighter in colour. You can see the mamelons are present. You've got this increased halo. That hasn't been worn down. It's generally shorter in height. You've got the gums sort of, sometimes there's obviously an element of eruption still occurring. So, and maybe gum recession hasn't occurred as we get older. These things tend to happen more. And then I try and simplify if I've got a young patient, sometimes I don't want to do 10 different colors. I want to always try and simplify my thought process, and so I always generally try and break it down into sort of, if I am going to restore something directly, and it is a young patient's tooth, I'm going to ideally, depending on if it's an enamel dentine fracture, I'm going to normally use a dentine shade and an enamel shade, or something that recreates the effects of what a dentine would be and what the enamel would be. So I'm always trying to simplify it, and in my mind when I say light medium dentine, I'm thinking the A1s, the A2 sort of territory, if we go on the classic sort of colour methodology that we normally think about. And when we talk about a light enamel, then enamels, as we'll go on to sort of discuss, is that really the hue of a tooth, the colour of a tooth, is normally derived by the dentine. And the enamel, I try and explain to my students, is yes, you can get chromatic and achromatic enamels, which sort of basically means enamels with sort of some element of colour to them, but what I would like you to think about enamels as is generally quite translucent, as they let a lot of light in, and that's what we're sort of looking for in a lot of our restoration, is this element of translucency but also opacity from the denting. So I'm generally thinking, how am I mixing these two elements together to create the most natural result? We know that in young teeth there's a lower mineral content but a higher water and protein levels, results in more scattering and less transparent enamel. Generally I find the dentine on young teeth is quite bright and opaque, so I'm always trying to think, how is my layering and the thickness of the material I'm going to use allow me to recreate the most natural restoration. Then I've broken it down into sort of senior teeth, so increased chromaticity in the body areas, that's the intensity of the yellow-red sort of spectrum of light, it's mainly because of the reduced enamel thickness and the sclerotic dentine that develop as we get older. Then I always, once again, simplify it into a double combination. If I am going to restore sort of like a class 4 on an older patient, am I thinking medium dark dentine, so we're leading towards sort of the A4s, the A3s, or A3.5, sort of that sort of territory? And are we thinking about what kind of enamel are we looking at? Are we looking for a bright sort of enamel or slightly darker toned enamel? So there's different properties to each of these materials, and we're not saying that you have to change all your systems and you need to have this composite or that composite. What the failure of most composites that are performed by most dentists is that their lack of understanding of their materials and how to apply it correctly. It's not generally the material's fault, it's our lack of understanding and being able to apply them. So what's really important for me is because I see people from all around the world with all different types of composite systems, and although I'm familiar with a lot of them, I try and explain that if you've got a system that works for you and you've got a methodology that works for you, that's great. But if you're not having consistent results where they are consistently, good, and that you're getting the optics that you want, then we need to sort of break down. There's obviously some planning issues or some lack of analysis in your layering protocol that needs to be looked at. So it's very rarely the material's fault. It's normally operator error, and I'm very, very, very critical of my own work. So I'm always thinking it's something that I've done, it's my fault, and I need to figure out the solution. We know in the older teeth that there's a higher mineral content but lower water and protein levels. That results in less scattering and more transparent enamel. What's interesting with older teeth is that if you look at, for example, these two images we've got on the left is just your normal sort of twin flash. On the right we have a polarized image, and it just takes out the flash reflective nature of it. But what you can see with a polarizing photograph is, if you look at the sort of the mesial and distal portions of the tooth, you'll notice it's more blue, it's a bit more translucent, because we've still got that sort of enamel effect on there, but it's been worn down at the edges. So, if we're recreating this tooth in reality, then do we need to add more blue or translucency towards the mesial and distal aspects? Do we in the middle need to add more more yellow tones or more tints to actually create that warmer tone that we see in the body on the middle third of the tooth? So it's a better analysis and a better looking at what we need to create, rather than just going, here's the tooth, let's just fill it. What I always do is just take a moment to step back and actually plan the case a little bit better. And you'll find if you take that few minutes or take that few seconds at least before you start a case, you'll find that your cases will become much more successful. And it's all about creating a systematic analysis. So dentine, we know generally roughly has about 70% mineral content, 20% organic, 10% water. It provides the chromaticity, the hue and the chroma. The dominant wavelength is the red-yellow in the V to A range. In general, as I said earlier, we want lighter composite dentine shades are more opaque and less translucent, while the darker composite dentine shades are more chromatic and more translucent. Now this depends on what dentine shades that you're using. Every manufacturer is a little bit different, but this is what I've just noticed over time. A lot of the dentine shade composites, they're bigger particles. If they're microhybrid or nanohybrid, you need to just analyze them and figure out how the optics behave and in what thickness. But generally we want the dentine shades to be optimized for light scattering, which basically means that we want the dentine layer to be relatively opaque. We don't want it to be, translucent, and then you'll get if you have a very translucent composite, you'll get this grey effect, and we don't really want that. We want some degree of opacity so that when light hits it, it reflects back, and it's creating the scattering that we need, that we see in natural teeth. Dentine shades, I generally, just because I've just been trained this way. I normally give them a slightly longer cure, but depends on your system. And for me, the most important factor, if I'm thinking a dentine shade composite, is the opacity, the handling of it, and the stability of the color. These are one of the critical things that I think we should all analyze and sort of assess over time. If we look at the enamel, generally they're smaller particles. Nano hybrids are, for me, phenomenal because they're optimized for easy polishing. If anyone sees a lot of my cases, the final layer will be something like Posterior, which we know just polishes beautifully and just maintains its color, maintains its shine. So it's one of my favorite composites. I've been using it for so long now, and I can quite honestly say it's one of the best I've ever used. So that's why I'm partly here, because if you're not using it, maybe like Posterior or Omega, these are my favorite sort of anterior layering composites. We always want to think about, can we create a transparent opalescent effect? Now, depending on your understanding of the systems, you need to realize, what shades. If, for example, if we take Posterior, are we using a natural enamel, a white enamel, an OCE? So you need to understand how these sort of enamel affect composites, how they look a bit different, how they behave, and how they're different with each other. And what's important as well, what thickness that you use those materials in. Because if you use a lot of enamel layer, more than, I would say, 0.5, or if you start going beyond 0.75, 1 mil of enamel layer, you'll start getting this, it will be too thick and it will be a lower value and it'll create a grey appearance. So it's important that with enamel composites, it's easy to blend, no air bubbles. When you're layering your final sort of enamel layer, I would like it to be one beautiful smooth layer. Don't fold it over itself and create air bubbles, okay? One of the most important things that I've learned over the years is that final top layer that you're going to put on, it needs to be really beautiful and smooth, okay? And then what you'll find is when you're polishing it back, that there's less air bubbles, there's less sort of uneven striations, and you'll get a much more homogeneous polish, okay? So these cases are just with Posterior, and they're not anything crazy. They're just simple, layering. That when we understand what kind of optics we want to achieve, then and what kind of patient we're looking at, then it gives us a better idea of, okay, well, this is the thickness that I need. This is where the fracture is. This is how the optics behave. Now, if you've got teeth either side, it gives you a little bit of a better way of sort of analyzing your layering. And, for example, if we look at the central in this case, we know that there's not a huge amount of translucency. So, what we need to be focusing on more is opacity and shape. So, we don't want a heavily translucent composite there, otherwise it will just look grey and very obvious. So you can see with that, with the other unrestored central, it's very flat, it's very straight. And these are the kind of cases we see all the time that people chip. And yes, you can use a single body shade, or if you want to just think of just one block color. But sometimes in these cases, a little bit of what you can't see, i.e. a little bit of denting with a layer of sort of enamel over the top, gives you a much more lifelike result. Because if we think about how light enters a natural tooth, it hits the enamel and then it hits the dentine, and the enamel and dentine are two different refractive indexes of light. Enamel's roughly around 1.62, 1.63, that sort of territory. And I think what dentine's like with the 1.54. I'll check that, but they're different spectrums of refractive nature to them. So they'll bounce and they'll produce this more natural optical effect rather than just using one homogeneous color. So I always like to sort of get the opacity but add this little layer of enamel as well, so that I get a more natural optic. And for example, one of the other, I put this in because one of the most common sort of restorations I do now is restoring guidance on people that they've lost, and it's really important. I can't stress how obvious by looking at people's occlusion, looking at the guidance, and how we can prevent so many issues and fractures and further wear by just looking at patients' occlusion and preventing problems. And if someone comes in with a fracture, we need to analyze a little bit better, not just the problem itself, but the root cause of the problem. So, and then, you know, using you know, very simple shades and very simple natural forms, you can create invisible restorations. And also it's so beneficial to the patient as well, restoring that guidance that no other dentist would have probably mentioned before, because, you know, there tends to be this sort of psychological mind frame that, you know, patient comes in with problem, we just deal with the problem and that's it. We don't really address the root cause of these problems. And to me, it's so important that we analyze these things. Good. Now, on my website, drth.co.uk, there is a quick a template. If you go to the FAQs section on my website. Now, this is a really cool guide. If you use Keynote or you can use PowerPoint, you can create shapes of teeth. And, you know, this comes back to my planning point, is how much planning do we need, and can it be helpful and done quickly? So you can see here, I've just created these shapes with these dots and moved them around on Keynote. And what I could do is create this template as a result. Now, this isn't a smile design per se, but it gives me a rough sort of schematic or outline as to symmetry, as to sort of ratios. And you can see how I can alter it by constraining the proportions if I need to and stretching it out. I generally don't constrain the proportions. I try to keep it I keep it all together. But what you can do is, if you take a photo of a patient, you've created this template, literally within 30 seconds you can just paste it on. I normally sort of put it on the center line and wiggle it around from there. But it just gives me if someone comes in and they want sort of a bit of a smile analysis, or go, how can I improve the look of teeth, or even my own work, if I've done some composite layering, how can I improve it? And sometimes I'll just do this quickly. It'll take 30 seconds and I'll just put it on and I'll go, this canine, I've layered it a bit too long. You can see there, it's just a bit too long compared to there. And then maybe this central's not as symmetrical with the other side. So it's these little attentions to detail that sometimes when we're layering or when we're doing dentistry, we don't see. That's why I always say the camera is as important as the drill, because we see things when we take photographs that we literally don't see with our eyes, and when we take the photo and then put a little bit of analysis on it, we just realize all our mistakes. And it's all these little things that still to this day that I do that helps allow me just to perfect a little bit more, get a bit better each time, and realize how idiotic I've been in my layering. When we talk about layering, it does get quite complex, so I'm not really going to go too crazy into this. I just basically want to roughly lead on from what I was saying before. A lot of the time we have worn edges of teeth, and you know, if they're tooth wear cases, yes, we'll do the full diagnostic wax ups in CR and plan the case as well. But we also need to plan, if we're going to do it, the layering aspect of it. And you know, yes, if you're doing a full mouth tooth wear case, there's an element to say transitional bonding is a really good idea, because you can dial in the occlusion, dial in a lot, let the patient get used to everything. So there's some functional benefits to that also. But when we look at these sort of worn down teeth, it's normally, you can see the dentine coming through, the enamel's being worn down, and then we think, well, okay, how can I create some translucency, some natural effect without, you know, well, in a short space? So, you know, one sort of way of looking at it is we always want some translucency at the back to allow the light to come through to create this translucent band incisally. Then we can add a body enamel composite, so something with a, you know, for example, an Posterior A2B or something like that. And if we want to, we can add a semi-translucent enamel. So if you wanted to add a white enamel or translucent enamel. So it depends on what kind of effect you're looking for, because the more translucent that top enamel you're layering over, the more of a translucent effect that you're going to get, and you can recreate halos, etc., etc. So, but it depends on each individual case and the optics needed for that. Now, sometimes it gets a little bit complicated, and what I try and do is saying, right, if you want optimum optics, in like natural optics with these teeth, sometimes having an enamel palatal shell, then adding an opega onto the area, if just to really make sure that you want to block out the light. If your dentine is not opaque enough, because sometimes you don't have much space, so a flowable opega, for example the Omnichroma blocker flowable that's just been released, it's fantastic for these sorts of things, because it hides that sharp transition light of natural tooth to your composite. So sometimes in those zones I'll use the Omnichroma blocker flowable just in that, just in my shell where it joins the tooth, to hide my transition line where it starts joining the tooth. So it's a really good idea. Also, then we'll layer the dentine, and then if we create mamelons, then we can seal that in with the effects and the translucent or natural enamel area, and then we can put, if you want, you can put a body composite, a thin layer of body composite, around about 0.5 over the top of that. Or if you want a very, very translucent, you can just add translucent enamel. So it depends on the effect that you want to achieve. So from my perspective, it's just, although it can get super complicated, but what I'm just trying to explain with this slide is to give you a rough idea of exactly sort of what is involved if you want to go super sort of into layering. And you can see with this patient with a bit of tooth wear that I just created very, very natural. You can see the blue, you can see the white, bit of edge bonding on this patient. That looks almost invisible, but there's a little bit of translucent, there's a little bit of halo, there's a little bit of colour in it. So, and that's what she was actually a special effects lady as well. So it was quite, I had to make sure that they were super natural for her. But it's, the point I'm trying to make is that you can go to as many layers as you need to, but it depends what kind of effect you can that you want to achieve, and understanding how our materials work in such instances can make the difference between something looking quite fake and just monotone, between something looking quite natural and realistic with some colour, with some translucency. So it's all really, it all relates together. Now, a lot of people know that I love my posterior direct composites, because I think it's one of the most demanding areas of dentistry, doing a lot of posterior. Although I see sort of anterior work as fun and dessert, actually, you know, posterior work I think is like, you know, you really have to work hard. You really have to, you know, it's almost underappreciated by a lot of patients how hard it is to be done. I think in many situations I work so hard creating these functionally beautiful composites, the patients will go, nah, that's all right. But whereas if I do something even simple on the anterior teeth, they're like, oh my god, this is amazing. So I do feel that sometimes posterior composite dentistry is sort of a little bit underappreciated by a lot of people, but a lot of our patients, but it's so critical. And when I look at, when I think about direct composites posteriorly, I always think about, what do I need? What's the perfect restoration? You know, get the right color, obviously, that we've talked about, the texture, the function, the contact points, the thickness of what the remaining walls are, and the thickness of the materials that we have to layer, the anatomical shape of the teeth, the cavity preparation itself, the emergence profile, the marginal adaptation. So these are just some of the factors, in no particular order, that we need to actually nail in order to get perfect, in order to get some invisible restoration. So it's a lot harder than sometimes we give it time and credit for. Sometimes we just think, oh, we can do this filling very, very quickly and it'll be fine. But really, it takes a lot of effort, a lot of attention to detail. So I always break things down into sort of 6 manageable sort of logical processes. So I always, whenever I see a case, I want a preoperative photo with the occlusal landmarks. In this case, we used omnichroma, so I'm just going to go through the case. I always take a photo of the pathology, so I need the patient to understand, you know, what I'm doing, why I'm doing it. They need to take ownership of the fact. They'll go, oh my god, that's my decay, that's horrendous. And that hopefully will make them change their behavior and look after their teeth and floss, etc. Sometimes it works, sometimes it doesn't, but I find that it's better to show them the reasons, their fractures, their decay, the problems that they've attended to see you with. Because if you just go, if you don't explain it, you don't show it, they don't take any ownership of their problems. So that's why it's really important from my perspective that every patient understands what I'm doing and why I'm doing it. Then we clean everything up. We tend to use Illumina 27 micron, and we just clean everything up that needs to be cleaned up, especially sort of white, hypermineralized or sharp edges. We want to remove the aprismatic enamel. We want to get the optimal bonding possible. Then I'll go for my matrixing. And then it's a really important photo to show, is there any gaps, is there any loss of seal. I always want to assess my contact point after I've restored it, and I take a 90-degree shot of that. And then this is the post-operative. I want to make sure that my occlusal contacts that were there at the beginning are not massively interfered with afterwards. So it's just simple logical steps and photos that I take for pretty much 99% of my cases to make sure that I'm keeping in the right path and I'm not making silly mistakes. In this case, probably a lot of you can spot the decay here. I tend to use a micro NSK handpiece for new virgin lesions, and I'll use a wedge guard to protect the adjacent tooth. Once again, I'll take the photo to show the patient the decay and go, this is why I'm doing this, and this is the care and attention I'm taking to protect your neighbouring teeth. I'll clean it. I'll matrix it. I'll decide if I'm going to use a flowable. Now, these are some of my favourite flowables. The Super Low by the Universal Super Low Flow is one of my favourites. It's slightly thicker, it's sort of less runny than the Estelite Flow Quick. So a lot of my injection moulding will be with the Super Low. Now, saying that, with the new Omnichroma Flowable, the thing that I love about is the consistency of it. So I think in this case, I think I wanted to use the new Flowable. So I think if we go to it, yeah, I'll use some Omnichroma Flowable. Now, there's two schools of thoughts. You can build up the wall with Omnichroma Flowable, but what I personally tend to do is I tend to line the cavity with my Flowable, and then I'll injection mold with the actual paste and not the flowable. Or I'll use a little bit of flowable and then inject the paste in, and it's almost like a snow plow technique where you get rid of any voids and any air bubbles by packing it in quite tight. So we like, Omnichroma Flowable, as well, the paste or the flowable. It works optimally if you think about it as a universal enamel. Don't think of it as massively replacing dentine. It's not going to give you that opacity that you need. You're going to have to use the Opega or the flowable Opega in order to achieve that. And that's it restored with Omnichroma relatively easily, and that will look invisible, I think. Yeah, I think you'll find that the colour is... one thing you need to be aware of Omnichroma, especially the paste, it starts out quite bright white when you're placing it, and then when you cure it, it will reflect the natural colour of the tooth. So don't be worried when you're first placing and going, oh my god, this is very white. Just cure it and you'll find that it sort of blends in very, very well. When you're layering, as I said earlier on, you can use a flowable base liner. In that case, I tend to either use the blocker, the Omnichroma flowable blocker, or I'll use the Super Low. I like the consistency of those flowables. Then you can put a dentine layer or an opaque layer of some sort, and then you can use your achromatic enamel. So posterior, you can use, depends on what you're doing. You can even use, as I showed in that example, you can use Omnichroma, or you can use natural enamel or white enamel. So I'm not particularly strict about that. I judge it on each individual case. In this example, once again, I take a photo of the decay to show the patient. I'll clean it up. I'll then put the Omnichroma blocker in just to hide any discoloration there. I generally place it around 0.5 to 1 millimeter thickness. It also sort of evens out and removes any sharp internal angles that I may have left. And in this case, I've used an Omnimatrix with a sectional matrix inside. And then for the other one, I've used just a sectional, I think, Tor VM matrix, and then I've flossed it and tied it. So the advantage of it is that because you have a missing tooth there, you've got no place to put a wedge in. So you can do these freehand, but I generally prefer that if I matrix it, I can inject, I can put flowable, I can build the tooth up without worrying too much about excess or it going over too much. So from my perspective, I always like to matrix it. I feel some security when I do that. And then I'll layer, I'll build up the wall with Omnichroma just so that I can create this encapsulated layer, and then I'll layer it over. I'll add, if I need to some white highlights. What you can even use is use the blocker as a little highlighter as well. So it can create very natural effect. So, I'll just go back here. So I'm just going to finish with this video of me layering, okay? And I'm just going to talk over it. So I'm building up my wall. I'm using the flowable for the internal line angle of the base of the cavity. I'm building everything up cusp by cusp, and I'm using a brush just to basically blend it in. You can either use a probe or a file, or I think in this case it's like a very fine Missouri instrument, and I'm just building everything up systematically and curing each part one by one. So you don't need to give each cusp a long build up. It's just a little bit at a time, and we're slowly building it up bit by bit. So I'm just going to skip towards the end where I'll just start layering it in. You can see just slowly, what I'll tend to use is maybe like an endodontic file, just to get little deep fissure grooves just all layered in there. And I'll remove the microscope filter. I'll check how it's looking. If I need to form the external oblique ridge or add some highlights, I'll do that as well. And I'm just recreating the natural anatomy of the tooth. And where I want it, I think in this case being a little bit fancy, I've sort of really tried to just add a few little extra details. Now you don't have to go to all this level of detail for every one of your composites. It's just showing, you know, how we would add the tint. We add it a little bit slowly, and then we try and remove as much of it as humanly possible. I'll even use the brush just to soak it all up and cure it, and then glycerin cure, and then I'll start my polishing. And these are my Ernst Vetter polishers that I love. Great company. It's called Eve Diacomp, and floss the contacts, and that's it. So thank you very much guys for joining me. It's taken a long time. I don't expect everyone. That's one of my first composites in 2008 that I had photographed. So thank you for taking the time to join me. If you have any questions, then give us a shout, and I'll try and answer them as best I can. It's a journey, and it's a fun one. Okay, bye.